talk about ventricular tachycardia. As always, this part will be management and this part will be the information regarding this. So ventricular tachycardia is a tachyarrhythmia originating from the ventricle. So it is a tachyarrhythmia originating from the ventricles, characterized by heart rate more than 100. That's why it is a tachycardia, beats per minute, with 3 consecutive ventricular beats. Okay, so it is more like this. Okay, now what are the types of tachycardia? We have multiple types. First, let's talk about clinical features. So as always, dyspnea, dizziness, chest pain, and sudden cardiac arrest. So as always, chest pain, palpitation, dyspnea, dizziness, sudden cardiac arrest due to ventricular fibrillation. Okay, what are the signs? Obviously, tachycardia, heart rate high, also along with tachycardia, PP should be high, but here is low because of impaired ventricular filling. Ventricle properly filled. Okay, Canon A wave, same seen in here. Okay, next is diagnostic criteria. In ECG, what can be seen? In ECG, heart rate will be shown as more than 100, so around 100 to 250, as seen here, same. But opposite to this, here PSPT we have narrow QRS, here I have wide QRS. Okay, long QRS more than 120 milliseconds. Okay, next is AV dissociation. What does it mean? It means atria and ventricle independent. Activity. Okay. Now in investigation, what can we see? Obviously, ECG is the first one. Then echocardiography for structural abnormality, cardiography. For structural abnormality, next is coronary angiopathy to rule out heart failure. Coronary rule out heart failure. Ischemic disease, rule out ischemic heart disease. Electrophysiologic studies, EPS. If I can remember, I will write it. And in lab, I have I have electrolytes. Check the potassium, magnesium, and calcium level. So potassium, calcium, magnesium level. In lab testing, I have also seen cardiac biomarkers. To rule out MI. Also, I have to check about drugs like digoxin toxicity. It's too much information, but I think it's easy and I can write it more or less anywhere. Let's talk about the management. So I have two type of patient. One is stable, one is unstable. So let's talk about both of them. If I have an unstable patient, so for him I will give immediate synchronized cardio version, same as before. How much it will be? 100 to 200 joules, increasing as needed, and increase. IV anti-arrhythmic drugs like IV amiodarone 150 mg for 10 minutes. Okay, lidocaine for ischemic ventricular tachycardia, and procainamide for alternate, as an alternate. Procainamide alternate. Next is treat the reversible cause. Treat reversible causes like electrolyte imbalance, balance the electrolytes. Okay, these three are for unstable. For stable, I have more or less the same thing. I have amiodarone, same drugs. Okay, amiodarone, lidocaine, procainamide, and if not working, then synchronized cardio version. Long-term management. I will keep beta blocker metoprolol. I here give amiodarone for recurrent VT patient, ventricular tachycardia patients. I can give these are the drugs. Let's talk about like I can give catheter ablation, implantable defibrillator, in between inflammatory cardioverter defibrillator, and at last I have lifestyle modification. Treat the cause. So that's the entire ventricular tachycardia.